with Ruger's work on shared health governance, I'm going to quote her paper, to create conditions in which all have the ability to be healthy. The shared health governance model sets out allocations of responsibility, resources, and sovereignty to a range of actors. And she names, for example, governments and communities and families and individuals themselves. And then she goes on to say that in this view of health governance, ethical commitments or the principles of conduct that are governing individuals or groups are really fundamental. And this is in conjunction, of course, with institutions and policies. And in Ruger's definition of shared health decision-making, some concepts are particularly important, like inclusive decision-making, shared commitment, public moral norms, shared resources, mutual collective accountability. Another framework where values play an essential role is the TAPIC framework from Greer and colleagues. And TAPIC stands for transparency, accountability, participation, integrity, and capacity. So you can see there that values are very explicit and front and center in that conceptualization. And this is true across governance frameworks. So Barbat-Santello and Pion have done extensive reviews of governance frameworks and found that values such as control of corruption or democracy, human rights, ethics, conflict prevention, public good, rule of law, these are all very much part of frameworks that have been developed over the years. So now moving on to the framework that we've developed specifically focused on governance capacities. I want to spend just a moment talking about what motivated this framework, given that we already have so many frameworks, what motivated this particular one? So we've already talked about how frameworks on health sector governance do have this component of principles and values, but they are multidimensional and multidisciplinary. They also include, for example, responsibilities and tasks like planning or policy development or regulation. And they also talk about these external challenges, which very much overlap certainly with principles and values, such as corruption or political instability. Now, moving on to ministries of health, there's been quite a lot of work done talking about ministries of health's role in terms of stewardship. And this is driven by the fact that ministries have this very explicit mandate to promote and ensure health and well-being for their populations. But what we noticed was that there were two key gaps. One was that there was a need for a framework that really brought all this thinking together, particularly from the perspective of ministries of health, given their very central role in health sector governance. And the second gap was that there was also a need for an actionable framework. So one that really addressed this issue of capacity, which is often identified as one of the main reasons for health systems failures. And so combining these ideas of governance and capacity, and then using this framework for strategy development or benchmarking, and of course, research as well. So moving on to the framework, and as I mentioned, this was already talked about in a previous webinar. So for the sake of time, I'll just run through it quickly, but please do see the other webinar, and then this report itself will be published very shortly. So kind of talking about the overarching approach that we took to this framework, we decided to look at governance, again, as a process, but then in two ways. One is the de jure governance processes, so the mandated or explicit or formal governance roles that a Ministry of Health is meant to play. And how these, and also the underlying soft or tacit aspects of governance. So for example, responding to context, changes in context, managing relationship, managing values, and how these then link up with performance areas. And I just noticed this screen at the bottom, apologies for that. And how these then lead to governance functions or performance areas. So starting at the top with the de jure governance processes, these include policy development, strategic planning, regulation, promotion of innovation, and increasingly, given sort of the change in concepts of governance, citizen empowerment. And then this then leads to the implementation of these de jure responsibilities. In terms of soft or tacit governance processes, preparing for and responding to changes in context, such as governing systems reform, such as decentralization, for example, managing crises, responding to political transitions, responding to other global shifts, this then leads to a governance function of being resilient and having relevance. The third is relationship management. So, how do ministries of health manage these relationships with their political leadership, with other ministries, with civil society and the private sector, with international organizations and donors, and of course other groups that are central to the health sector. And then finally, the focus of today, which is values management. So this was initially a longer list, but we narrowed it down to three in particular, which we felt were most important in this context. But certainly, this is open to many more ideas as well. Accountability and transparency, participation, and efficiency. And these then lead to propagating certain values and, of course, alignment. I'm sorry, I'm just trying to move my screen. There you go. So now thinking about capacities. So our ideas around capacity were derived from Potter and Brow's framework of a hierarchy of capacity needs. And Potter and Brow really think about capacity as a pyramid where you require certain capacities such as structure and then that eventually builds onto other types of capacities such as personal capacity. We really flattened it out in this context and selected six in particular. One, the first is role capacity. So starting on the right side. So what is the formal authority, responsibility, and legitimacy given to make decisions? What is personal capacity? It's the knowledge, skills, and motivation to perform these duties. And personal capacity is very much about the capacity of the staff in ministries of health. Third capacity is workload capacity. This pertains to skill mix. So given all those various governance roles, you need a very diverse staff to undertake those roles. The next is performance capacity. So do you have the necessary resources such as funding and infrastructure to support Ministry of Health staff and these structures in doing these activities? The fifth is supervisory capacity, so looking at internal reporting, monitoring, and accountability structures. And finally, structural capacity, which is the existence of these mechanisms like decision-making fora, structures, committees, commissions, in order to have this work take place. So bringing all of this together, we see that governance roles, such as the ones we just talked about, really work through these various capacities to then lead to these governance functions or performance areas. So now moving on to the values management piece. I'm going to quote from the paper. And this quote basically says, in the end, as a governance body, an MOH must adopt and actively manage certain values or principles. Underlying these norms is the view that a shared approach to governance involving whole of government and whole of society is preferable to that of a narrow, overly centralized view of health and health governance. And as we talked about, this includes processes like accountability and transparency, participation, and efficiency. So now, what are the governance capacities specifically in terms of values management? These are some examples from the paper, and I would welcome your thoughts on these or other examples that you can think of during the discussion period. So thinking about personal capacity, is there capacity for stakeholder negotiation and mediation? Role capacity, the authority, responsibility, and legitimacy for decision making. Structural capacity, do we have the mechanisms for the various aspects that we just talked about, such as formal stakeholder fora? Do we have enough resources to support these? And even though this isn't an explicit part of the paper, it's very important to also think about systemic capacity. So what is the capacity of the system as a whole, of all the other groups within the network to engage with ministries of health? And this then facilitates also more engagement with networks as opposed to individuals, which in our literature review and I think in everyone's experience is very common. Now, just a note here that it's certainly important that we have all these capacities, but we also have to acknowledge that they don't exist in a vacuum. And there's very much the influence of context, such as colonialism and political context, that influence how these capacities emerge and whether they're given a space even to exist. It also depends on institutional norms, which builds off of context. And then public norms are also very important in shaping how these capacities emerge. So here are some examples from the paper that will be released shortly, and you can read these and the underlying articles in more detail there. But just to kind of give you a flavor for some of the ways in which values have been promoted through governance by ministries of health. So one example is the National Health Assembly in Thailand. This was built into legislation in the National Health Act in 2007, and it's an annual assembly that brings together civil society, government, and academia, for example. In India, in the mid-2000s, the National Rural Health Mission undertook an effort to build in communitization into the reform. This led to the existence of mechanisms such as the advisory group on community action and a plan of work around community action. But then it had very varied outcomes in terms of how this was implemented at the local level, and also had to undergo some shifts due to political changes that took place. This is outlined in the paper by Gatonde and colleagues. Participatory health councils in Brazil also exist at the national, national, state, and local level, but struggle with role capacity in the sense that the decisions taken by these councils do not often find their way back into policy, and they're also not given sufficient resources to function. There have been efforts to address corruption in contracts processes. In Benin, this was done through the technology procurement section of the Ministry of Health. In Afghanistan, this was done in the contracting office that pertained to public-private partnerships. And this is an example of learning organizations, which is going to be the focus of the next webinar. So very much looking forward to that. One example from Mongolia is where they try to build in this capacity to shift the thinking around learning organizations, create more openness and reflection and community focus. Finally, another approach that could be taken starts at sort of the very top levels of the ministry. Harvard, for example, runs this Ministry of Leadership and Health program, and it's very much focused on building the capacity of ministers of health in certain areas, and they've had success, particularly in working with ministers of health to articulate their legacies, build political support, negotiate budgets. But one could imagine, even though this isn't explicit in the literature, one could imagine that this is an interesting avenue then to also try and promote this idea of values management as well. So just some concluding thoughts, and very much look forward to Dr. Venkatapuram and Dr. Abimbola's comments. Working towards an ethical health system and realizing social justice and reducing inequities is clearly rooted in broader social action and commitment. And even though these ministries of health are part of this broader fabric, they do in the present have a role to play in making progress on these goals. They certainly have to exist in this broader context and are shaped by the broader context, but they can also shape the broader context, as I think the other speakers are going to address in more detail. So this framework is outlining capacities that ministries of health can draw upon now to take steps in that direction. How can they build their capacities in the present day in order to move the needle? And our hope is that future iterations of this framework, and this is very much a framework that's meant to be applied and built upon and further developed, hopefully there can be some more work done to develop these ideas around values management, and to also consider more system-wide and then indigenous, locally driven approaches that emphasize values as part of a Ministry of Health's governance portfolio. So I just want to end with some acknowledgements. I want to acknowledge Kabir Sheikh, who led this work and led the development of the framework, and our colleagues in the Health Systems Governance Collaborative, Mariam Begdeli, Agnes Sukat, Ben Rufi, Ben Lane, Godlee Van Hedren, Sandy Campbell, and then to all the other colleagues in the collaborative who provided very valuable input. So with that, I will end and look forward to your comments.
Thank you, Veena, for that presentation and for setting the scene for today's discussion. So now I'm going to turn to our second panelist, Sridhar Venkatapuram. Sridhar, the floor is now yours.
Fantastic, Ben. Thank you very much, and thank you, Veena, for a really great presentation. Hello, everyone, and thank you very much for attending this evening's webinar. So I'm going to spend the next 10 minutes both building on and sort of also examining some of the points that have been made in the report. And what I'd like to begin with is start with these 2 points that the report makes, that the Ministry of Health has 2 responsibilities in relation to values. One is that the Ministry of Health should reflect social values in functioning, and at the same time, the Ministry of Health should lead on social values, or to be sort of motivate society to get behind certain kinds of social values. And so to try to understand both of those 2 points and to think through how that might be able to happen, I want to first start from sort of a position or sort of a reflection as someone who works in ethics and normative reasoning, and looking at this report, is that it functions in 2 different ways. One is that it is bringing together the state-of-the-art literature on what we know and what we understand about ministries of health and their different functions, their capacities, what kinds of different functions, what kind of different capacities, and how can we ensure that these roles are recognized and understood. At the same time, the report is also essentially laying a model for the way that ministries of health should be. So it's a very interesting dual role of both a descriptive sort of analysis, but also a prescriptive analysis about what we think that ministries of health should look like and how should they function, and how do we ensure by recognizing all the different parts that we give sufficient attention to. So in that way, I'm sort of very sort of interested in the idea of what should be and what should the roles of the Ministry of Health should be, and what the values should be that ministries of health should expound and practice. And so one of the questions that I have is the way that we use the concept, or the way that we use language of values, principles, morals, norms. There seems to be a lot of different ways that we can use these words, and it's not clear to me as to what we're talking about when. So, for example, are good governance principles the same as social values? And can we say that when we're talking about things like anti-corruption or efficiency, is that the same as saying these are the social values that we are reflecting in the work that we do in Ministries of Health? I think one of the things that's happening and what we need to pay closer attention to is to distinguish between ethical social values and principles of good governance. And I don't know, and I would like to learn from you and also in the discussion about whether you think that this is an important distinction or not. I think that there are different ways to describe whether Ministry of Health is working well and if it's doing its job well, and versus whether the right social values are being expressed in the way that it's working well. So I'd like to focus a little bit on the existing social values that operate in Ministries of Health, and whether we think that we have anything to say about whether certain kinds of social values are good or not, or whether they could be better, or whether they should be different, and whether we think that there is some sort of universal values, social values, that it should exist in all ministries of health, or whether we think that each society should have its own particular social values, and we can't say very much about what each society decides to reflect in terms of their social values. So for example, let me take 3 kinds of social values that appear in the work of Ministries of Health. The first kind of social value that I see in sort of various kinds of public health programs that Ministries of Health implement is this idea of trying to maximize the good that we try to produce, or that maximize the well-being of people as possible. So when we think about public health programs that seek to achieve, say, maximum number of cases averted, or maximum number of vaccinations, or try to maximize the number of people that have gotten access to different kinds of healthcare, what we are trying to say is that one of our social values is that we want to help as many people as possible in achieving their health and well-being. And I think that this is a very important and good social value. And I think that it's something that we often see throughout ministries of health around the world, something that we could see as being social value that exists in ministries of health. At the same time, we also see in various kinds of health programs, whether it be public health or healthcare in a more individual level, this idea of cost efficiency, which is also driven by this idea of trying to help as many people as possible. But it's a much more sort of complex idea that we want to help as many people as possible given the available resources. And that too, I think, expresses a social value in a particular kind, which is that we want to help as many people as possible, the greatest good for the greatest money. And it's also a valuable sort of social value that requires acknowledging and addressing. Now, in contrast to this idea in public health that we want to do as much good as possible, or we want to be as maximize our good given our resources as possible, there's also been in various different countries this idea that every citizen has a basic right to healthcare or a basic right to health. And the idea is that despite our one social value that we want to help as many people as possible, we also need to acknowledge that every individual in the country and society has a claim to assistance regarding their health. And we do now see that there is different kinds of conflicts between these two kinds of social values. But there's also many other things going on in ministries of health and the different kinds of policies that they implement, which may not be explicit, which may not be sort of well articulated, but they're at play. So we might have health programs for particular groups of people. So whether it be women, whether it be for older people, whether it be for children, these are all sort of expressions of social values about protecting and promoting the interests of certain groups of people because of a variety of different, for different reasons. So in terms of the way that the current, in the way that the report sort of discusses it, and more importantly, in the way that all the literature that they have cited in the report talks about it, is that they talk about generally how the health system, the Ministry of Health, sort of needs to manage values, needs to acknowledge sort of shared values and moral norms. But no one here is actually articulating which specific moral norms that should be sort of expressed in the Ministry of Health, or which sort of values should be expressed in the Ministry of Health. And I think this is really my sort of interest and concern, is not that values exist or they need to be shared or they need to be managed, but which values are we going to be articulating? Which values are we sort of addressing? Which values are we recommending, given that we are recommending a model Ministry of Health? So at the same time, while I've given you some examples of what kind of social values are already expressed in the Ministry of Health, we also need to acknowledge that there are various kinds of values that are being expressed at a global level, whether it be through global health policy recommendations, global health guidelines, as well as funding priorities. So we have, for example, from the biggest philanthropic foundations, various kinds of values about which kinds of health issues are more important than others. And underlying that then shows a priority of which lives that we think are sort of more important to help rather than others. The argument we also see at a global level is the argument for human rights, and particularly the rights of marginalized groups who are vulnerable groups, as well as more overarching human right to health. Now, these kinds of arguments have ebbed and flowed over different decades. So in the 1990s, the arguments for human rights and the right to health was profoundly influential and has sort of shaped a variety of different policies. But now we have less so. We have different human rights, and the right to health seems to be less influential rather than other kinds of social values. In particular, the SDGs express two different kinds of values. On the one hand, we have this idea that every country must strive towards ensuring the health and well-being of their people, but also we have divisions about different kinds of goals as to what they should achieve. But within that, we have on the one hand the idea that the right thing to do is to achieve these targets in each one of these SDG3s, but at the same time, we have another goal, which is that we can't be time. So we have two different kinds of value. One, an ethicist would sort of label this as, on the one hand, you have this idea of maximizing impact in order to achieve sort of targets, and on the other hand, you have a prioritarian view, which is that you need to give priority to the worst off in order to raise their well-being. But there is obviously, this could be going in two different directions. And so we have both a global policy that's sort of giving you two divergent values that kind of go in different directions. And even at the national and the sub-regional and local, will face this kind of hidden social values as well. So the last part that I want to talk about is and it's a very selfish and sort of way of presenting this idea, which is that in health systems and policy research, there's been enormous valuable social science research that has pointed out various kinds of examples of inequity and injustice that happens in health systems or non-existent and weak health systems. And I think this has been an incredibly valuable contribution that has motivated others in order to look at health systems more generally and try to understand how we can govern and how we can identify good governance principles in order to ensure that everybody is sort of benefiting from health systems. However, I think that we need to go beyond, on the one hand, identifying examples of inequity and injustice, to also to move towards a more normative, ethical conversation about what we think should be the various kinds of ethical positions and principles that should govern health systems. And it is often the case that by talking about what is wrong with health systems, we often make various kinds of judgments of what we think should be in the health system, or what the right health system should be, or what it looks like, without really thinking through some of the values and social values that we are implicitly asserting in that kind of position. I think there's a lot more to be said about this, but what I want to sort of come back to and sort of in a summary say is that the report is fantastic in that it gives us a very good map of what a Ministry of Health is, what it does, but at the same time, it also tells us what a Ministry of Health should be like and what it should do. Fundamental to that is that the Ministry of Health both expresses various kinds of social values, but also it needs to shape, motivate, and advocate for transformation of various kinds of social values. My question really is, what are those social values? Are there universal social values that we want to be able to advocate when we also advocate a Ministry of Health model? And also, how do we develop the capacity of people in the Ministry of Health to articulate their values and to reason through and develop their value system? And how do we then also, at a global level, develop and articulate the social values that we want to see across ministries of health? And how do we develop the capacity of people who are working in global health and global health governance to articulate social values and various kinds of conflicts that will happen? So with that, I look forward to our discussion. Thank you.
Thank you very much, Sridhar, for these initial questions, and we look forward to having the panelists' comments on those, on what are the differences, if any, between ethical social values and the principles of good governance, and the social values that we implicitly uh, embed in our social systems and health systems. Before we open the floor to the discussion, I'm going to turn now to our third panelist, Shreya Bimbola. Shreya, the floor is now yours.
Thank you very much. It's good morning from here in Sydney. And thanks once again for having me to the Health System Governance Collaborative. I am not an ethicist like Sridhar. So what I'm going to do is try to bring the conversation to some practical realities that often emerge in health systems. And whenever I read a paper like the one Vina presented, or whenever I see a new framework, my mind always goes to how it applies in places that I know. And there's nowhere that I know better than Nigeria. So that was where my mind went to. And I will speak as someone who has worked in the Ministry of Health and who has since been obsessed with thinking about governance, often because of the work that I did and sometimes continue to do in places that look very much like Ministries of Health. And I've tried to imagine how especially how the values components of this framework may work in Nigeria, and what this means for a Ministry of Health in a place like Nigeria. And I'm going to do this sort of reflection based on two examples that immediately came to mind when I saw the framework. The first is corruption, and the second is performance. And I suppose my main point in making these two examples is to illustrate how that Ministries of Health exist within a broader governance framework. In other words, Ministries of Health are themselves governed entities, even though as this framework makes absolutely clear, they are also governing entities. They also, in a sense, make rules, they change rules, they monitor rules, they enforce rules within the health system. So they govern as well, as much as they are governed. And I hope that these two examples will stimulate some similar reflections during the discussion section. So first, corruption. Now, corruption is beginning to attract a lot of attention in global health and in health systems research. And I think it's a good thing because one of the things that come out very clearly in current explorations of corruption, I see some of which have been in Nigeria and broadly in West Africa, is that in many situations, the corrupt practices that you see in the health system are themselves adaptation to corrupt practices elsewhere. In other words, the corruption you see in health systems reflects corruption outside of the health system. And in many instances, this corruption exists at levels that are higher than the health system, which in turn, of course, makes corruption possible in Ministry of Health, and then which in many instances translates through many chains of action and inaction to corrupt practices at lower levels. Now, as a side comment, one of the things that as health systems researchers, as people who practice within health systems, it's often much easier for us certainly to shine a light on corruption in the low places, because the power differential between those of us who do that and those corruption we are shining a light is such that we are able to do so. But in many instances, the real origin is high up in the system. And the question that I think is worth thinking about in the light of this framework is can health systems exist as an island within a broader society and political system that are often far more powerful in determining the values in which the health system then rates. And the when I see corruption in low places, one of the things that strike me is that the performance of the health system at those low levels often depend on a kind of corruption. That if you were to remove the ability to, quote and unquote, be corrupt at that level, what you're potentially doing is perhaps more harm. And again, the question comes to mind. Of course, a place that has no corruption is a place where there is justice. And a place like I've just sketchily described, in which you remove the corruption, is a place that also then loses efficiency or loses ability to perform in some way. And I wonder again how to think about this in the context of this framework. The second example I'm going to make is more historical. If you work in primary healthcare in Nigeria, there's a constant nostalgic recollection from people who have worked in the system for a long time. And they will talk very in glowing terms about how in the second half of the 1980s, how that Nigeria was performing excellently, especially in immunization coverage and other sort of basic primary healthcare indices. And of course, that statement is made in the assumption that the values that allowed such performance to happen are not to be questioned. And I'll explain what I mean by that. Now, in the 1980s in Nigeria, there was a repressive military dictatorship, such that an otherwise organically decentralized country was run centrally, and a particularly brilliant and effective minister was appointed, who essentially made sure that the primary health care system in the country really functioned really well. And of course, it functioned really well in part, if not mostly, because um, the democratic self-determination that you get in a politically decentralized system was essentially quashed, such that it was far more easy to make things happen. And today, there are several low-income countries in which the reality is not very far from this, where you find ministries of health performing excellently, or at least beyond expectation, or beyond what the country's socioeconomic status may suggest. But then you realize that that level of performance often would depend on a certain, almost a trade-off with social justice. So you find high levels of coverage of one index or the other, and then the more you open the box on that, the more you realize that just like it was in 1980s Nigeria, that there is a certain kind of trade-off there between the ability of the system to perform at the level at which it performs, and a certain extent, and a lack of social justice to a certain extent. And again, I wonder how to think about this, and something I think about a lot. And also, what does this framework tell us about such circumstances? Again, I've made the examples that I've made, I'm concluding now, to highlight the fact that ministries of health exist within a broader context. They are governed entities, and also to reflect on a point made by Vina in her presentation, that again, these systems and the ministries of health operate within a historical context. There are institutional norms that emerge over time, and that the norms of the public and the norms of the governing political system, of course, shape the capacity of the Ministry of Health to both set norms and the ways in which it responds to the norms set for it.
Thank you, Shea, for your intervention. And I think it really resonates well with what Sridhar hinted at, principally with the idea that efficiency from a ministry perspective can be very different from producing social justice. And thank you also for pointing out that we could also, well, the ministries are never an island, and sometimes they're not even the best equipped to actually manage the values and diffuse them in the health system. So at this point, we're gonna open the floor to questions and comments from the audience. So if you have a question or a comment, you can just raise your hand electronically or type it in your chat box. I'm gonna give you a second to raise your hand if you have a question. To kickstart the discussion, I have my colleague Ben Lane that's here with me, and he has a question.
I'm sticking my neck out here. Hello, everybody. This is a terrific, wonderful, fascinating comments on a great paper and observations. And so it's kind of a leading question, and it may also be something that's completely obvious to everybody, and I miss the point. But I mean, I really, when we have in the paper, we're talking that we see in the paper that, or in the presentation, you know, the discussion of values management. For me, that's always been, you know, what kind of values are we talking about? What is it? What is actually in you know, what is the breadth of that? And you all have you know, sort of teased that out very nicely. And I'm wondering, is it reasonable to, you know, have in a discussion to say, well, look, we're talking about, it's, I don't want to say hierarchy, but I'm going to say hierarchy. I mean, they're the sorts of values that apply to the political sphere. And I think a lot of what Sridhar is talking about are things that, you know, these are values that are, it's the political part of government as well, to be saying, are we taking a utilitarian approach, or are we taking a, you know, what sort of public health approach are we taking? Of course, it's informed by public health expertise or whatever, but it's fundamentally a decision about how society is going to orient itself. But then there are the other values, which are sort of more in the public administration realm, which are the world that I'm always used to living in, which are, you know, what is it to do the right thing as a public administrator or as a civil servant, say? And obviously that cuts into the corruption, goes into the corruption discussion, but it also has to do with, you know, behaving right, and for a functionary or a function of a within a government. And so I'm wondering, it seems entirely compatible, the two approaches that you're talking about, and I'm wondering whether or not it's foolish of me to think in terms of a hierarchy, even though I don't mean one's better than the other. I just mean one is more at one level of policy and one is more at administrative level. So shoot me down. And also, I'm really looking forward to hearing you all sort of discuss what each other have to say to each other.
Thank you, Ben. We have other people starting to raise their hands, but I'm gonna go first to Sridhar to give his initial response to that comment. Sridhar, you have the floor.
Thanks. I'll be really quick. I think that's an excellent sort of distinction to be made between sort of what you call public administration values and social values. So I think that you're also right. Like, it's not a hierarchy. What you're doing is just sort of disaggregating the concept of values from one being the broader social sort of justice values, or how a good society is, or what the vision of the society is that's dominant, versus sort of as a public administration, you know, what are the values within public administration? So I guess I agree with that wholeheartedly. I have no sort of reason to disagree with it. One of the ways that I would distinguish it is between sort of personal morality as an individual who works within the health system, and sort of social ethics and social values. And so, there is, a lot of people, including someone I teach with at the London School of Hygiene, named John Porter, who continuously argues that you can't realize social justice without being able to align it with your own personal moral behavior. And so, individuals, social justice is actually reflected in the way that individuals act and behave in their everyday life in institutions, particularly the health system and the Ministry of Health. So that's right to distinguish between public administration and social values. It's right, I think, also to distinguish between personal moral behavior and social ethics. But also, I think that we should also think about how we express social justice through the personal behavior and values of our everyday functioning within an organization or an institution. Thanks.
Thank you, Sridhar. I'm now also going to go to Veena for a quick comment on that, especially maybe on how you reconcile this public administration and the public health views together in the frameworks. Veena.
Thank you, and thanks to everyone. It's so great to hear all these comments from the panelists, and then also Ben's question was excellent. So I think this kind of leads to a reaction to Sridhar's comments as well. In that, I think the overarching idea with the framework is that while it's suggesting, it's a first attempt at articulating some of these ideas that could shape how a Ministry of Health thinks about its governance function roles and its capacities. This very much has to be adapted at the national level. And this, I think, is in line with what everyone has said here, in that it would be very difficult to sort of articulate and, first of all, define these and articulate these ideas. It would sort of not be practicing good governance in a way if we do this in this very sort of closed elite way in some sense. This very much has to be driven at the national level and driven within countries and part of a broader project around ethics and social norms. So I think this idea of how you select what values a Ministry of Health is promoting, whether you define that as a hierarchy or not, I think that very much has to be a discussion that's happening at that level. And this is just one sort of attempt at articulating some of that, but it can be built upon and going forward. The other idea is sort of, I think, in addition to this idea of balancing public administration and sort of social ethics and values, there's an interesting tension there, in that if, say, one of the social values is broader participation or broader societal participation, then how does that sort of feed into into that public administration idea? For example, there was an interesting point in the Ruger paper that by having too much of this emphasis on collective responsibility around decision making, does it lead to fatigue just from the part of civil society, in that they're being asked to do tasks that they may see as more of a government's responsibility or role? So there are all these interesting questions around collaborative governance that I think need to be worked out, that very much sit in this intersection between public administration and social values. And just to make a quick comment to Shay's point about Ministries of Health not existing in an island, I completely agree. And that any ministry is shaped by the government it sits in, and of course the society it sits in. But just to kind of give an example from India, I think my sense is that yes, ministries are shaped by the broader government, but when a ministry does start to sort of show some signs of doing things better, if you will, of succeeding in some of these, improving in some of these capacities, I think it does have an effect on the public and seeing that, okay, this is what a ministry can do. So I would just argue that yes, they are not islands, but they can be important norm setters for government as a whole. So I'll stop there. Thanks again for the comments and questions.
Thank you very much, Veena. Celia, I'm going to give you a chance also to comment on that, and then we'll turn to another questions.
Just to respond quickly to Veena's last point. yes, of course, they can do that, and there are many examples here and there when Ministries of Health have been able to, by their performance and also by the visibility of health in society, been able to set some norms. So yes, absolutely, I take your point. Um, something else that came to mind as the conversation about public administration and social value was going on was also how to think about roles of ministries of health in decentralized settings, right? So when you look at a place like India or Nigeria or Ethiopia, you'd find that there are many ministries of health within a country, and depending on the constitution of the country, they could operate very, very independent of each other, as is the case, for example, in Nigeria, and I assume largely in India as well, such that there will be ministries of health within the country that could be islands of this brilliance that you described. And again, there are examples of that in India and in Nigeria, where you find that the Ministry of Health in a particular state does so particularly well that it becomes a thing people look at. As an example. And I just wanted to insert that conversation about the possibility of multiple ministries of health in an environment, and the possibility that one ministry of health or several of the multiple can then actually be the norm setters for similar subnational ministries of health and even for the national ministry.
Thank you very much, Sayed. So we have a question from the floor, and that's more directed at Vina because it's about the framework. Okikyolu is asking that, yeah, sometimes there might be also tensions between the administration, the bureaucracy, and values. And his question is, how does the framework may explain how MOH behaves in such cases? So, Vina, you have the floor first.
No, I think that's an excellent question, and certainly sort of one of the ways in which I think this framework can actually be used from a research perspective. Um, so again, I think the idea behind this is to sort of see the framework as a way to promote perhaps certain types of governance roles, but then to also use it as a way to assess what exists within the country, and also from a research standpoint. So, I mean, my response to that is that I fully agree that there is a tension there that potentially the ministry might define a certain set of values, but those may not be practiced uh, by the bureaucracy as a collective, or, for example, some individuals within the bureaucracy. And my sense is there that some work then would need to be done in terms of assessing where those gaps are regarding mechanisms or regarding other types of capacities to help bridge that gap. But it's a really excellent question.
Thank you, Vina. Before I give a chance for our other panelists to react to that, we have also a question from the floor that I'm going to try to get. Gladys, separately, you have a question, so I'm giving you the floor now, if you can just ask it. Gladys, are you there?
Yes, I am, but my kids are awake, so it will be very noisy. I'll prefer to just chat, please. Thank you.
Okay, thank you. So while Gladys is typing a question, I will give a chance to Shea to also give his view on how we can explore those tensions between bureaucracy and values. Shea?
Yeah, yes. The thought that comes to mind there is, I think perhaps going to the point Ben Lane made earlier and Frida's response about how there are public administration values and there are social values, and they could be separate. And I wonder whether the Ministry of Health has stronger leverage in enacting public administration values much more than it does with social values. And I say this reflecting amateurishly about how often the values within a public administration could be thought of in more technical terms than, say, social values. In other words, there are values that could be influenced within, that values that could be, in fact, I imagine, improved by training, etc. So that it's more tangible and more movable, I suppose, than social values. Just quick reflection.
Thank you very much, Seye. Sridhar, would you also care to comment on that point?
No, I don't have very much to say because I don't, we haven't talked about values or which values yet. We're still sort of talking about sort of conflicts and values of different groups. And, I completely agree that there are different conflicts of values. I think there's lots of different kinds of conflicts. So, I think corruption is a great example because what's happening here is just self-interest is a value. And so, corruption is very much an expression of self-interest as, a strong and dominating value in it. And it's a conflict with sort of the, sort of greater other kinds of social values that exist. So I have no sort of further sort of insight into what different kinds of conflicts there are or anything else. But what I do think is that, if we actually articulate certain values as being valuable or important for society or for Ministry of Health, then that at least begins the discussion about sort of saying, well, sort of the bureaucratic values or the public administration values are either in line with these or are not, and therefore they need to better reflect these values, or the public administration should be sort of saying that those values are not the right ones, and we think that these other ones should be the ones that we sort of emphasize in the work that we do. Thanks.
Thank you very much, Sridhar, for this precision and this invitation to go more on what type of value discussion we should put forward. We have a question from the floor from Munira. Munira, you have the floor now. Munira? Hello? Okay, so apparently our connection might not be so good either. So we'll just give a second to Gladys to finish typing a question.
Can I ask Vina a question?
Yes, please.
I was wondering how you see this framework, its potential as an instrument for practitioners versus its potential as an instrument for researchers. In other words, was this designed and written and conceptualized as something that will help people in Ministries of Health do their work better, or something that will help researchers understand what is going on within Ministries of Health better?
Excellent question. And at the danger of being all things to all people, I think it would be both. But it was initiated earlier in the governance collaborative. Sort of Kabir's mandate was to develop this framework that I think a lot of it did have to do with the sort of practical side of it in terms of providing guidance to ministries of health for how to approach governance capacities. That was its origin, and I think it evolved in a way that the idea was that it could move beyond that to not just being sort of a tool, but something that can be used for research and assessment. And I think that's probably common of many frameworks, at least, that they live in both worlds. But its an initial intent, I think, was around action. But just to say that, I think the initial intent was also very much that, again, this was a sort of and it's one approach, and it's a suggested way of thinking about these issues, but one that then has to be further thought through and adapted and built upon. So it was never meant to sort of be the final word, but rather something that can be evolved going forward depending on context. Great question.
Very much, Vina.
Yeah.
Oh, I'm giving back the floor to Ben Lane. Was an observation also.
Hi. Yeah, I should not be talking so much, but I just love this stuff, and it's just so exciting to have all three of you together. Vina, would you just, in talking about where what the contribution can be and where we go with where we see you going with the paper and the model or the framework, and this in the context of the earlier discussion, I mean, it just sort of it brought back to me experiences in working with ministries with incredibly inspiring ministries, where there was a conflict between very legitimate values on a regular basis, and that people in the ministry guiding the ministry, but also the civil servants working there had to sort through. And it was the conflict between public health values that, so if assuming that there's some that that are sort of broadly enough held that that it had some critical mass, which of course I think there are some like that. But then also there were some good governance, public health, public administration values, particularly with regards to public financial management, or also more country-specific ones related to ethics, the ethos of how the civil service should work in a given country. And people would find themselves sort of crosswise, where as a public health specialist with a very strong view about what they ought to be doing, they were having to negotiate that in terms of also, as a civil servant, having a very strong view of what they should be doing, and sometimes in a completely different direction. And maybe it's a naive example, but it's something that I felt rather viscerally when I was working with my colleagues in ministries. And I'm wondering whether or not there's something in this framework that might allow a safe discussion of that sort of thing.
Okay.
Just to quickly respond to that. Oh, sorry. Just to really quickly respond to that. I think absolutely that one of sort of the intentions of it could be that it allows for that kind of a discussion to potentially then take place in order to set a sort of a prospective mission or plan, or I'm not using the right word, but in order to think about this prospectively, maybe something like this framework could sort of serve as the basis for that kind of a discussion. That's one approach that could be taken.
Thank you, Vina. So we're going to take a few more questions, and then we'll have to close this session. First, we have a question from Godly Van Etten. It's a two-part question. First, to Vina, if we see the current frameworks on governance roles and capacities MOH as an organic instrument, where practically should we focus next steps in applying the instrument? The second question is to Sridhar, and it says, how would you practically envisage building capacity in MOHs to critically articulate values, tacit and otherwise? In Europe, we had a wave of explicit ethical deliberation in ministries in the 90s, but that practice died recently. So I'm first going to Vina for the questions, steps, and then to Sridhar.
Thank you for that question. And I would defer to governance collaborative colleagues on this point, but I think my idea for it could be that it sort of serves as the basis for potentially a series of discussions at the country level or the regional level in terms of understanding what resonates, what perhaps needs some adaptation, maybe assessing ministries of health based on this framework in terms of understanding how it is applicable, what kind of information is it gathering about the capacity within a Ministry of Health at the moment. So I would see it sort of going in both those directions potentially. And again, this I defer to collaborative colleagues on this one, as a basis for conversation and further dialogue at regionally and nationally, but then also perhaps serving as the basis for case studies of certain ministries of health, nationally and subnationally.
Thank you very much. Well, yes, I think we very much agree with that, and we'll consultations with the different collaborative members that are interested in that topic to see where they could see the next steps and how you could field test the framework to make it more relevant for practitioners. I'm turning now to Sridhar for that second part of the question, which was about building capacity in MOHs to articulate values.
Great, thank you very much. So, what I see currently in terms of ministries of health or health systems where ethics are clearly articulated or deliberated about, one is that in the research ethics governance, or if there are in the health systems of various countries, various kinds of bodies that look at different kinds of research approval procedures, what you find is a very clear kind of set of tools of ethical ideas that are just deliberated, and we can discuss whether you think that they're good or bad or strong or efficient or worthwhile and all. But that's one point at which sort of ethics are clearly discussed in that way. The second place that ethics in the health Ministry of Health or health system is in committees that decide on sort of health budgets and rationing of healthcare. There's usually various kinds of discussions about how do we decide which kinds of health services are we going to provide, and how and why, and what are the different reasons, and how do we make difficult decisions. So I think those two places have been, that exist. What we are talking about is a much broader sort of conversation about ethics, not just research ethics or not just on priority setting, but also in terms of what is the purpose of the Ministry of Health and the health system? What are we trying to achieve? How, what are the methods that we believe are acceptable or not acceptable? What is the notion or understanding of equity that we have? What do we sort of assume to be? We have to have some sort of principles that guide us in sort of developing policies and implementing. So I think that there is quite possible to have public deliberations on these issues. There's also a role for ministries of health to actually explain the different kinds of social ethics and values that are implicit or need to be made explicit in different kinds of health policies going forward. In the UHC agenda, it would be, I think, fantastic if rather than simply saying, we are trying to achieve universal health coverage and this is the instructions that we've received and therefore we're following that, but rather to be able to say these are the kinds of underlying principles that have identified these particular healthcare programs to be realized in this order, and so we agree with them in these sort of ways, or we don't disagree with them, and we're sort of considering how to do it. So I think there's lots and lots of different ways in which and points at which we could develop opportunities for people to articulate the values of the society, and also to be able to reason across different kinds of conflicts and see if there's sort of progress to be made in some sort of shared understanding of some of the agreements and how to move forward on where there's agreement. Thanks.
Sridhar, before we go to the last comments from our three panelists, I'm going to take two last questions that are related to each other. First from Gladys, who asked, please explain how the framework addresses corruption, since bureaucracy is mostly the order of the day in many ministries of health, and practices are prevalent and mostly given as directives which must be obeyed by top management officials. The second part is from Godlieve, who asked, since you pointed out that MOHs are governed organizations as well as governing ones, in some places, MOHs are governed to the extent that they sell out on some of their core stated values. What could value management amount to in such settings? So I'm gonna give you the floor to address these questions on corruption.
These are tough questions to wrap my head around. To Godlive's question, and I'll come to Gladys' question through that. And speaking to Godlive's question from the perspective of corruption, which of course is a clear example of a way in which sometimes actors in the health system are asked to act in ways that contravene the values that should underpin the health system. there's often an assumption, I think, which is questionable, that ministries of health by themselves, acting because of their own goodwill, will do good things. And to my mind, as I was arguing earlier, ministries of health also respond to societies. They respond to people. They respond to civil society. They respond to community expectations. And I think in thinking about how to make ministries of health especially behave in ways that perhaps will go against dictates from higher up, is perhaps to make dictates from lower down sufficiently compelling. In other words, um, I can imagine a scenario in which people in communities are sufficiently informed and sufficiently astute as to what they should expect of their health system, such that it becomes progressively more difficult for the Ministry of Health to behave in ways that the people do not see as right. And I suppose this goes a bit to the issue raised by Gladys as well. That although there are often these dictates from higher up that would either excuse or encourage or in fact mandate corruption, ultimately the way out of that is to have a populace, a people, from the lowest levels to the highest, who are sufficiently aware of what to expect and have channels through which to demand them or to express displeasure when what they expect is not behavior they expect is not.
Thank you to all of you who attend this webinar and challenged our your excellent questions. I'm now going to do a quick round of final comments from our panelists, and then we'll close this session for today. Sridhar, I'm going to start with you. If you have any final comments, please, you have the floor.
So thank you very much. So just very quickly, I think a couple of things that I really liked and I'm going to go away to think about is that I think Say sort of brought this out, which is that, what role does ethics have next to power? And, what is it supposed to do? So we can either benefit from a beneficent individual who governs the health system and sort of say that's great governance, or we can suffer under someone who has poor ethics. But can articulating ethics and developing them and building capacity, can that somehow influence power, and can it actually sort of modulate the way that the health system works? I don't know if that's an empirical question, and I don't know what the answer is, but I think that that's one of the things that I've learned from this, and I definitely want to go away from with it. The second thing is that I think the growing attention to corruption is a really important and valuable thing. But one of the things that we haven't done very well, both as ethicists, but also I think more generally, is to kind of make an, sort of actually make an argument as to why corruption in the health system is a bad thing and why it may be different from, say, corruption in the business sector or corruption in other places. I think that, for someone who is, so I won't go into details for that, but I think that we just haven't done enough to actually articulate what is morally wrong and ethically wrong with corruption, particularly in the health system, and why this is one of the worst things that could happen. So I think that might be some potential way forward as well. But thank you very much for teaching me both of these things.
Very much, Sridhar, for those final comments and for proposing to explore what's the relevance for corruption, especially for the health system. So yeah, I'm coming back to you now for your final comments.
Thank you again for having me and for nice conversations. I've enjoyed this very much. One of the things that the conversation sort of got me thinking about was how then does change happen? And I'm wondering here about the kinds of change that can happen by simple, if we can use the word simple here, by simple capacity building. So I mean, we've talked about political problems, ethical problems, power problems, and I'm wondering here if we're thinking about change, are there the kinds are there changes we could effect by simply building capacity? And what are those? And what are the kinds of change that need something else to achieve? And I think this framework has potential in helping us, I think a bit more clearly about that question, even how it sort of matches capacities with values, etc. The second thing that I will leave thinking about is also how the structure, the overall structure of governance in a place, in a setting, can constrain Ministry of Health. Constrain it whether to do good or constrain it whether to do things that are not so good. So in other words, can we also then, in terms of thinking about change, imagine scenarios in which the design features of Ministry of Health, whether or not it has clear pathways for civil society contribution and activities, whether it has clear pathways for community level engagement, whether it has clear accountability relationships with other sectors or other levels of government within a setting, how those structures affect the ability of the Ministry of Health to either be value creating or value responding entities.
Thank you very much, Sheye. So now Vina, the floor is yours for the final comments.
Thank you so much, and thank you again for the opportunity to be here. It was such a tremendous discussion, learned a great deal from everyone. I think I just want to build off of what Shay just said and note that it would be fascinating, I think, for this community of people working in this area to maybe start articulating or doing some empirical work around what are examples of ministries of health or subnational ministries or departments of health where change has happened or is happening, and then to try and understand why it's happening. What are some of the, as Shay mentioned, design pathways, or what are some of those sort of soft, more tacit aspects of governance that have been drawn upon in order to make change successful? I think it'd be really interesting to again apply this hardware and software approach of trying to understand how this is happening and to try to understand these examples in more detail. And the framework is one way of doing that, but then I think there just could be also broader approaches of doing in-depth work and understanding examples of successful efforts in this space. Similarly, I think one idea that came to mind as Sridhar and Gottlieb were talking was, can we articulate some of these ways in which we can have a discussion around values at the national level? So sort of taking this values piece and broadening it out in terms of explicit steps potentially in understanding how this conversation can happen. And yes, looking forward to further discussions going forward.
Thank you very much to all three panelists, Sridhar, Vina, and Seye, for taking the time to make all these excellent points. And thank you also to all who attended and challenged us to think a bit more about this, how ethics is involved and how it reflects on governance roles and capacities of Ministry of Health. I'm going to remind you that the recording from this session will be made available if you missed the beginning or just want to relive it. And also, this is the second part of this webinar series around governance roles and capacities of Ministries of Health. And the third part will be scheduled in January, taking a different lens on with a learning organization perspective. Thank you very much. Also keep an eye for the release of the full WHO working paper. It was a pleasure to have you today, and see you soon. Thank you.